Hi everyone, Retfix and Chill is back again with another live episode. This time from Orlando in 2025 at AAO. I have the great honor and privilege to be here with my friend, Buffalo's very own fellow Mets fan from New York Pioneer of Mount Sinai, Gareth Lema. Gareth, welcome back, buddy.
Hey, thanks, Sauer. It's really an honor to be here. As you know, I'm a fan of Retfix and Chill, and so I'm happy to talk about this protocol that we've been working on at New York Pioneer. It's something that for me has both been a project that comes out of passion, but also a bit of a full circle moment. When I was in training, I was interested in neurology for a while. My research was in that. I actually enjoyed the stroke service when I was on it, and so to work with stroke teams again has been a lot of fun.
Yeah, super cool. I think, it's a paradigm shift. So Gareth has been working on some protocols that totally change how we manage CRAOs. Patients would come to CRAOs, we'd say, hey, go make sure you don't have another stroke and go find the clot, but we'll see what happens in the eyes. But now there's some potential to improve vision. So, when we're not at Mets games, this is what we do. We talk about how to address CRAOs. So, Gareth, tell us how this project came to be and how this has changed how we treat CRAOs.
Yeah, so what we really are doing is our role in ophthalmology is really to help the stroke service diagnose a retinal artery occlusion better. And it's something that's not really set up at a lot of stroke centers, and that's why CRAO has not been treated for so long, because it's something where a CRAO comes in, you have to call the ophthalmology service. If you have an ophthalmology service, the resident has to come in, they transfer the information to a faculty member, they discuss the case with the faculty member. Maybe the faculty member feels comfortable saying, yeah, it's a CRAO and you can treat. Maybe they want to see the patient themselves. After you do this, it takes 2 to 4 hours to see a patient, and you're really out of the window just in diagnostic time. And when I first got to New York Pioneer, actually Dr. Rosen said, we're trying to treat CRAOs, why don't you come to this meeting? We'll be based up in Mount Sinai. So I went to this meeting with the stroke service, and we were talking about who's going to do the OCT, and Dr. Rosen had an OCT in mind that he wanted to use. We thought residents might do it, and really the epiphany we had was just, if we really want to do this and we really want to diagnose faster, we have to get the ophthalmology consult out of the equation. And it wasn't anything against our residents, obviously, it just takes too long. In New York City, it takes 45 minutes to get to the hospital. So what we worked on was a protocol on how can we scale this down and make it efficient enough that the stroke team can get the data, and we can then interpret the data and tell them safely if it's a retinal artery occlusion. It took a bunch of steps to determine what we need and what we don't need, but we learned a lot, and I think CRAO is great, but this translates really well to any ocular emergency, and how can we manage or diagnose ocular emergencies remotely in real time. So first off, with our protocol, what we've done is basically we designed it so that anyone comes in with painless monocular vision loss, or really in the stroke world, painless unilateral one-sided vision loss is already part of their paradigm. So this didn't change much in who gets worked up or who causes a stroke code or starts a stroke code in the ED. So the ED side, there wasn't much to change. What had to happen after that is the stroke team goes in, collects some data for us. They collect very baseline data, everything within a neurologist's scope or field of expert, vision. I put an ear card next to the device, just some basic history, just to rule out things like giant cell arteritis. That's still a clinical diagnosis, and there are multiple physicians involved here, so we really have eliminated giant cell arteritis when it's come in. And then check pupils, things like that. Then collect an OCT. We chose an OCT that is basically point and shoot. I do some training every year. I work with the neurology residents, and I train them as to how to use the machine, train them about the protocol, things like that. It's a grand rounds. You know what I mean? It's not a huge training session. A lot of times they're walking up to it and using it for the first time, seeing it for the first time, and we've always gotten usable data from it. So having kind of a simple device that doesn't take a lot of training is important. The buy-in from both teams has also been very important, and it's something that I'm happy that we've had a lot of collaboration. Once an OCT is acquired, it can be transmitted to the consultant in any way that sort of fits in with your health system. In our case, you can literally take a photograph of the screen, eliminate HIPAA-compliant data, obviously. Programs like Epic have nice features. You can photograph in the EMR itself. So whatever your system is set up to do, you can use that communication. For us, staying in this sort of goal of streamlining and keeping things simple, we just basically use the parallel system to the stroke team. So we said the stroke team has their lines of communication set up. If we change it too much, they're not going to do it.
Sure.
And so it was really, really important just to have a parallel system. But we also couldn't burden the retina specialists, because if we started getting all the stroke information, then we would tune out and just not pay attention. They get stroke stuff every couple of hours. But what we did instead, we set up just a parallel line of communication so that we can work together. Another important feature, especially as retina specialists, we're surgical retina, and so we couldn't set up a traditional call system, because we knew that if one of us is in the OR, you can't respond. And we really had to have a mechanism where we could respond within 5 minutes. So there's 4 of us who just were interested in this, wanted to see if we can make it happen. And basically every one of us gets a message that there might be a CRAO. At least one of us responds, usually it's 2 or 3 of us, and then they'll transmit the information to us so that we can make the diagnosis. If one of us is not available, they can always go to the fellow on call. They typically know where we are. One, I guess, other important feature of it was, what do we eliminate and what do we not get? Photography came up. And obviously photography adds a huge amount of information, especially when looking for a CRAO. I mean, a cherry red spot is what we're trained to look for. Sure. But it also didn't add anything to the OCT. OCT has very pathognomonic findings for a CRAO or for retinal ischemia, and so it wasn't necessary. Ultrasound came up. A lot of emergency rooms have ultrasound capabilities, obviously. Emergency medicine physicians are trained many times in emergency ultrasound, especially for the eyes, and they know how to do it. And so we could have added that, but it would have added a step. It may have added the need for some expertise. And we kind of recognized that the things we're looking for are vitreous hemorrhage or retinal detachment. Well, a shallow retinal detachment or a mild vitreous hemorrhage you can find on OCT. Yeah. And if they're bad enough, the OCT fails. And that brings up the final point is we're not trying to just sign people up for TPA. Right. We instituted in the protocol not a fail-safe, but just if there's any indication that maybe this is not a CRAO, then it triggers a full ophthalmology consult or transfer to one of our sites that has a full ophthalmology consult available. Sure. So those are some of the tips on how it's set up.
Super interesting. I think one thing that I noticed with this is that the goal is to minimize the amount of time to get the diagnosis. So I think that's awesome. 2 questions. First off, so say me as a retina specialist or our community of ophthalmologists and optometrists, say they make a diagnosis of CRAO. Or say, me as a retina specialist, I say, hey, go to New York Eye and Ear because you have a CRAO. Can we cut some of these steps get cut out, or is it still the same protocol?
That's a great question. That came up kind of early too, actually, in the protocol. When we published it last year, we had already incorporated that because we were talking about it, and people were becoming aware that we were doing this. And so, there are times I get a text from a friend who says I have a CRAO.
Like me. Hey, bro, exactly. Where are you at?
And so... we do, and we did incorporate. If someone reaches out to us personally, then we'll tell the stroke service, look, this is coming from a retina specialist, or this is coming from a comprehensive ophthalmologist or an optometrist. Yeah. We do ask that you send me pictures, or whoever you're reaching out to, you got to send some pictures. We have to verify it. So basically, if we can verify the diagnosis, the patient comes in, then it can bypass some of those steps, as long as we can verify the diagnosis. And if we can't, we always have the OCT machine there. It takes the machine we're using takes 2 minutes to scan both eyes.
I love that you use OCT because even with if you have early reperfusion after a CRAO, I guess you don't necessarily always see a full cherry red spot, or if it's transient. Yeah. So I think it's great to use OCT.
So we've actually found, this is kind of interesting, that we published a case report over the summer in JVRD, but we have a few cases like this. For the patients where we've tracked OCT sort of days apart, we're actually seeing changes in real time in the treated patients. So rather than having the interretinal thickening that you see with a CRAO, it kind of converts to sort of a PAM type picture, because the areas that are basically reperfused lose that thickening pretty quickly. It's been remarkable to see that change.
So I think this is super exciting. I want to hear a little bit about what you've seen in the patients. How many of these patients, first off, do you have a hard time, is it like a certain number of hours, and if it's beyond that number of hours, then they're not in the window of TPA, because, if someone comes in at 8 hours and 1 minute, is that something that's completely a wash? it's hard to study these things. So I want to hear about like how many of these patients are regaining vision. And I encourage everyone to read the paper. It's super interesting and exciting. But I also want to hear about some of this extended criteria, because it's nice to be able to tell our patients that all hope is not lost.
Yeah. So obviously getting minutes count. And in stroke they say time is brain, and we say time is retina. It's the same exact thing. Minutes count. Basically, if you see someone with a CRAO, get an OCT, get some pictures. Don't wait for a fluorescein.
Right.
Send patients right in. We're willing to treat within 12 hours. Our service. I always say, I tell people all the time, I don't tell the stroke team how to treat strokes. And so for the most part, using intra-arterial TPA, it's injected directly into the ophthalmic artery. And we're willing to treat within 12 hours. The timing is a bit of something to talk about. Right now, the American Heart Association recommends treating with intravenous TPA within 4.5 hours. They had a paper that came out a few years ago that made CRAO a medical as well as an ophthalmic emergency in line with stroke, and they recommended that form of treatment. It did discuss intra-arterial TPA. There was a suggestion to treat within 6 hours, but really open-ended. It wasn't described in the text where they came to that. We decided on 12 for a couple reasons. The Eagle trial was controversial. Part of the problem was that they treated too long. Their mean was almost 13 hours, and so we knew we didn't want to go further than that. We also had done pilot data where our stroke team had treated 15 patients before we did this, and we wanted to make sure we weren't going to cause harm. So we looked at those patients, and out of the 15, I think it was about 60% gained 3 lines of vision or better. The mean change was to about 2100, but what really got me passionate about this was that 4 of the patients went from count fingers or worse to 20/80 or better, which really is life-changing.
It's huge.
Life-changing visual recovery.
Yeah.
And I really felt like if we did that, if we kept doing this, and maybe we'd get more patients in that group than in the other. 3 of those were within 7 hours, and 1 was at 11 hours. So we decided to stay at treating within 12 hours, and we'll see. If you ask me, I think an inflection point might be at around 7 hours.
I think, what's cool is, I've seen this program implemented in a lot of academic centers in bigger cities. And I think that's great. For example, at NYU, in one of the Long Island sites, they have a maestro and I get pictures. It's like, hey, do you think this is a CRAO? I'm like, that's an eyelash. But no, I think it's been cool to see it implemented. But what I think is most exciting is how do we incorporate this in a sort of national, global setting. For example, not every hospital is equipped for trauma. Not every hospital has IR that is capable of doing intra-arterial TPA or doesn't feel comfortable with it. What are your thoughts? And this is sort of like the future. Like, how do you see this implemented, candidly in the national setting? Is this something that we need to have ERs divert people with monocular vision loss to specific hubs, or do we tell ambulances, like, if someone has monocular vision loss, don't go to this place, go to this place where they have intra-arterial TPA available? These are challenging logistical things to set up.
Because stroke is looking at eyes now, so part of the BFAST acronym, the E is eyes. So because of that, I'd like to hope that on the EMT side, you do have patients going to stroke centers when they have monocular vision loss. But I don't know. So that would be something that would be really important to get patients to the right place first. In terms of more remote ophthalmology, you mentioned the Maestro. Cameras like that are amazing, and I think for us, and actually when we were starting this, I need one of those. And I think for diagnosing anything in ophthalmology, I think that's incredibly powerful. The limitation really of the OCT is you can't really do much with it. A lot outside of this. I can't diagnose anything I need a photograph of. I can't diagnose it, and sometimes the neurology team is like, "Oh, can you see this on the OCT?" I'm like, "Yeah, we can't." I can't diagnose everything. We can diagnose a handful of things. So I think to your point, with remote ophthalmology, cameras that the cameras like the Maestro get OCT, they get a fundus image within seconds. Having things like that, I think, would allow even remote hospitals to identify these. And then because we have remote communication, remote diagnosis, you could send it to an expert who can make the diagnosis for you and tell that hospital where the best place to send the patient is, whether it's a stroke center, academic center, or what they need next.
Yeah, super cool. So I'd encourage everyone to read the study. Came out last year, right?
Last year in ophthalmology.
In ophthalmology. Great sort of data showing the promise of this protocol. And I mean, I'm just, as retina specialists, as our general ophthalmology, our other ophthalmology colleagues, our optometry colleagues, and if you see a CRAO, it's very time sensitive for us to get these patients into a center that has this capability, because it's, as you mentioned, it could be vision saving. It can also potentially, I want to hear like, all right, well, this reperfusion, are we able to reduce the rates of neovascularization, neovascular glaucoma, and things like that result in ptysis and loss of the eye? So this is potentially a massive game changer.
That's a whole other discussion. One last thing, just that needs to be said. Even if you can't treat, the standard of care is to get patients into a stroke center to evaluate their risk of cerebral strokes. And so, up to 25% of patients who are diagnosed with CRAO have evidence of some kind of intracranial ischemia at the time of the diagnosis, and there is a heightened risk of having a cerebral stroke in the month after your CRAO. And so it's really, even if you're not able to treat or in a place where they have treatment available, getting patients into a stroke center or a good neurology department to evaluate their risk of an actual stroke is incredibly important and can be life-saving.
Yeah, absolutely. I think it's always helpful to honestly get on the phone with the ER. Sometimes I do that. I mean, if I'm sending someone to the ER for what stroke workup, like for example, if I see someone who has an episode of amaurosis, just getting on the ER, be like, hey, this is a patient that had amaurosis. Please check for GCA. And I just I give them a little like prescription pad, to do thromboembolic workup so they can activate the stroke code, because a lot of times patients go to the ER, they don't really know how to convey their vision loss, and then they're sitting there and you're losing precious time. And even if they might not have a CRAO, they might have something else, that puts them at risk for a cerebral stroke. Gareth, thank you so much for sharing this awesome protocol. It's exciting times, paradigm shifting for the treatment of CRAO, and encourage everyone to read the paper. Thank you, Gareth.
Thanks, Sarah.
Let's go Mets, baby.